postoperative fever of unknown origin. This land, ravaged by a nuclear war, this land has become soured. Everything is scarce. The oil wars turned human against human, and now gasoline is more valuable than water to this car-worshipping society. Welcome to the wasteland, the first stop on our tour of the post-apocalypse world, and home to Crazy Carl. Carl? Like our clinical case patient? Let's review his case. Carl is a 64-year-old male who is 3 days out from his nephrectomy for stage 2 renal cancer. There's a lot going on here, but the question is asking what the most likely cause of his fever is. So let's focus in on the important points for this question. So, uneventful surgery, he stayed for some pain, and now he's got a fever up to 101 this morning, and sounds like it happened overnight too. Vital signs are otherwise okie dokie. He's on a number of medications. None seem to really jump out at me as suspicious for his fever. He's reporting some urinary symptoms that are new since removing his Foley catheter. Could they just be from having the catheter in? As well as having some redness and pain at his IV site. Of note, on labs, patient does not have leukocytosis, and the rest of his labs look pretty normal. His creatinine bumped a little, but that can be explained by having his kidney removed. Cool. No leukocytosis, so we can go home. He's fine, right? No, of course not, or this isn't sketchy medical. Whoa, toasty guitar, man. Like a post-apocalyptic drummer boy getting all the war dogs pumped and ready for attack. I wonder who they're chasing. Let's be honest, it's probably that crazy Carl trying to save some poor bossman's wives with the help of a rogue war dog lieutenant. Like this hot guitar, postoperative fever is most often defined as a regular fever, meaning a temperature of greater than 38 degrees Celsius or 100.4 degrees Fahrenheit. Patients be feeling hot. While every fever should be evaluated promptly, very high fevers, meaning 40 degrees C or greater than 104 degree F, may indicate serious and potentially life-threatening causes and should be evaluated urgently. Fever develops due to the release of cytokines, hence the dropping cytocoins. IL-6 is the most closely correlated with fever. Cytokines are released in response to tissue trauma sustained during surgery and the generalized inflammatory state associated with surgery. The more tissue trauma, the more cytokines that are released, and the greater the fever response. Thus, large surgeries, significant inflammatory conditions, or actual traumatic injuries with significant disruption of tissue may just cause a fever all by themselves. These tissue trauma fevers are self-limited, so they're not going to send your patient off to the eternal highways of Valhalla just by themselves. But it's important that there are no other clinical signs of other causes before we say this is the cause of a postoperative fever. However, we're more worried about what else can cause postoperative fevers, particularly in our clinical case patient. While we talk, there's a few groups of people to keep in mind, however. The old ball and chain. The boss has got you shackled right to the front of the truck, because you're not a human in their minds. You're just a post-apocalyptic hype beast. Not all post-surgical patients will adequately mount a fever response, whether self-limited or caused by something else. NSAIDs and glucocorticoids suppress the release of cytokines and can blunt the fever, so we've brought in our recurring symbols for both of these. Glucocorticoids even blunt the whole immune system, rendering a patient immunocompromised. Immunocompromised patients, including those taking cancer chemotherapy, transplant immunosuppressive medications, or glucocorticoids, as we just said, as well as elderly patients, war dogs with leukemia from existing in a world ravaged by nuclear fallout, or patients with chronic kidney disease, may have trouble mounting a normal fever response. For our clinical case patient, he's got cancer, but there's no mention of chemotherapy, nor is he likely to get chemo anytime soon, since it delays healing and all. Whoa, look out, here comes the cavalry. Or the carvalry, I guess. There's no need to go all crazy about these fevers like you do about getting guzzling, since there's a convenient way to classify causes of postoperative fevers, which is by their timing after surgery. Immediate fevers, like our immediately threatening spiky car, occur right after or within hours after surgery, often from drug or blood product reactions. Because they occur so fast, they are rarely due to infection, unless the infection was present before the surgery. Fevers that occur within the first week after surgery are acute fevers. This is where we're talking for our clinical case patient, since his was 3 days after surgery. Subacute fevers occur 1 to 4 weeks after surgery. And finally, delayed fevers occur after 4 weeks. These categories are how we will organize our fevers, and as we bring in symbols for all the different causes, they'll be located on the appropriately timed assault vehicle. Another important distinction to make is that there are both infectious causes and non-infectious causes. We'll go into more details on these later, but because it's so important to mention, the most common infectious causes of fever in the post-op period are surgical site infection, pneumonia, UTI, and IV catheter infection. The most common non-infectious cause of fever in the post-op period is a drug-related fever. Radiation from nuclear fallouts falls into this category too, which these war dogs have to deal with. Aha, I'll bet for our clinical case patient that he's got one of these. High on my list based on this are both the UTI or the IV catheter infection. Okay, now let's start getting into the causes. Look out, dude, jump on one of the rigs! I don't think the bosses will care about you getting run over when they're in pursuit of their targets. Gotta get their wives back and teach that crazy Carl and rogue infuriator a lesson. And make sure not to kick those grenades while you're at it. A useful mnemonic for remembering the very common causes of postoperative fever is the 5 W's, like these 5 little clouds remind us: wind, water, wound, walking, and wonder drugs. Some sources give each W a specific post-op day or days when a fever most likely is from that particular W, but those don't actually hold up in real life. Here at Sketchy, we use the 5 W's as a convenient way to remember the most common causes, noting that the W's, for the most part, fall into the acute and subacute timing categories, which is why these symbols are around the acute and subacute big wheel truck. Wind should make you think of breathing, meaning pulmonary causes. The reason that wind is first in this very classic mnemonic is because of atelectasis. While atelectasis is frequent following surgery, happening during the first 24 to 48 hours, usually due to poor ventilation, and it can lead to many other pulmonary complications, it, in and of itself, is not a cause of fever. It just happens to have an association with fever, which is felt to be mostly coincidental, so cross that off the list, like this collapsed airbag is crossed out by the marks on the windshield. But still keep it in mind, because some resources and attendings still use it as the beginning of the wind category. Moving on from that, there are a few other important pulmonary-associated causes of fever. Aspiration of gastric contents can occur in the perioperative period, resulting in chemical-mediated inflammation of the lungs, called chemical or aspiration pneumonitis. Turns out you can also get this from breathing this radioactive air in the wasteland. And definitely by breathing in the bugs. Blech. If secondary bacterial infection occurs, typically from normal airway or stomach flora, it becomes an aspiration pneumonia. Patients at risk for aspiration include those with an NG tube in place, dysphagia, or depressed consciousness, and or a decreased gag reflex. Importantly, aspiration may occur during the process of intubation as well. Whoa, Boss Man Jack himself, all tricked out and ready for war. Dude does not look good, though. Like, he's a few breaths away from just keeling over dead. Let's end the pulmonary section on a biggie. Pneumonia, which is why we've brought in more dirty lung stains. Pneumonia falls into the acute timing category, typically occurring in the first 5 days after surgery. It also represents one of the most common causes of fever in the postoperative period. In particular, for patients maintained on a ventilator for longer than 48 hours, ventilator-associated pneumonia is a big concern when a fever is seen, and must be ruled out in these patients, symbolized here by Bossman's ventilator. For patients not on a ventilator, meaning those extubated immediately after surgery, we're talking hospital-acquired pneumonia, with our recurring Red Cross symbol for pneumonia. For initial workup, you would start with an X-ray, symbolized by our favorite skull and crossbones X-ray symbol. But apart from that, we're not going to get into all the dirty details of identification, workup, and management of pneumonia here. It's much too complicated for this sketch. Be sure to check out our pneumonia sketches in our internal medicine course. Well, nothing in wind sounded like it fits our clinical case patient, but water is next, and I'll bet we hit something there. That's right. Get some nice, refreshing radioactive water right from your radiator. That's a smart idea. Think it's yellow from the radioactiveness or just because someone peed in it? Ugh. Water refers to UTIs, which are commonly associated with perioperative urinary catheterization in the acute period, frequently between days 3 and 5 after surgery. Catheterization is relatively routine for many surgeries, especially lengthy ones. The risk of UTI goes up as the time of catheterization goes up, so to minimize the risk of infection, the urinary catheter should be removed as soon as safely possible. So our clinical case patient Carl definitely had a Foley in, so he's at risk. And heck, he's right at post-op day 3. Here, we've brought in our recurring UTI martini glass, shaped like a bladder, complete with ureter straws and a urethral stem, and just a hint of extra protein with that bug, to check out signs and symptoms. Fever is the most common sign. Symptoms of UTI are pretty nonspecific when the catheter is still in, and unfortunately, they may also be present in patients just with a catheter in place. Once the catheter has been removed, the more classic UTI symptoms of burning dysuria, urgency, and frequency pop up, like they did in our clinical case patient. I think we have a great guess. How would we diagnose it, though? It seems like we don't have enough information for that yet. More bugs. Tasty. The diagnosis is made when bacteria are seen on urinalysis, with the presence of signs and or symptoms of a UTI in a catheterized or recently catheterized patient. Treatment is typically removal of the catheter or replacement if the catheter is still needed, and antibiotics, which are initially empiric and then tailored to urine cultures when possible. Check out our internal medicine UTI videos for more information on workup and treatment. Snazzy decorations, but those definitely add drag to the car. Might want to think of that when you're, trying to run down your enemies at top speed, but I get it. You can't always sacrifice style for efficiency. Otherwise, what's the point of life? The next W is for wound, meaning infections, and these usually present in the subacute period, or towards the end of the acute period, which is why these symbols are closer to the back of this big wheel truck. We're going to talk a lot more about wounds in our wound sketch, but here are the basics. Anytime we disrupt the skin, infection can occur, especially when you're running around in a giant wasteland of infective and radioactive dirt. I mean, come on, it's gross out here. Normal skin flora are usually the culprits. Signs and symptoms can include classic signs of infection, including redness, pain and tenderness, warmth, swelling, and murky fluid or purulence from the wound. Diagnosis is made clinically, but the wound may be cultured to aid in antibiotic selection. Treatment includes opening the wound and possibly antibiotics, depending on the extent and seriousness of the infection. All this doesn't fit our clinical case patient, really. Next, we need to slide over to our immediate flying spike car to talk about one very serious cause of wound infection, which is necrotizing soft tissue infection. We'll cover these in detail in its own sketch, but here it is important to note that they may cause immediate fevers within hours of a surgery, and these fevers can be very high. Prompt evaluation and treatment is required. Classically, they're associated by rapidly spreading signs of infection that we just discussed and dirty dishwater-colored fluid leakage, meaning a gross gray-brown, from the wound, like this dirt oil coming out of this car. Hope you don't need that to keep the car running. Otherwise, it's going to be tough to reach Crazy Carl and his merry band of runaways. The organisms involved are typically Group A Streptococcus, GAS, and Clostridium perfringens, so we've brought in our recurring symbols, a pi for strep pyogenes, and gangrenous gas due to C. perfringens association with gas gangrene, which is actually a type of an STI. Powerful broad-spectrum antibiotics are, of course, needed emergently, but more importantly, they require truly emergent surgical evaluation for debridement. The wound category should also make you think of catheters that break the skin, of which there are many types. The most common of which is the good old peripheral IV catheter, which should remind you of our clinical case patient. Any catheter or tube site going into the skin or coming out can become infected, typically at least 48 hours after placement. Again, normal skin flora are the most common cause. Diagnosis is again clinical. Signs and symptoms are of a skin infection around the site of the catheter, including redness, pain and tenderness, warmth, swelling, and purulence from the site. With our clinical case patient having just some redness and tenderness, an infection might be impending, but he's not there yet. If a clot within the vein is involved, often with purulent fluid coming out of the site, we call it suppurative phlebitis. Treatment involves removing the catheter, which can be replaced in a clean site if it's still needed, and usually antibiotics. So, okay. Our clinical case patient likely has a UTI based on his symptoms, but probably doesn't have a full-blown IV catheter infection. But we should still probably avoid one by removing his IV catheter and either replacing it or seeing if he even needs to have an IV still. Let's finish up these W's.
Yeah, V8, witness me!
Whoa, little intense there, bud. Like, I get it that it's part of your car culture worshipping religion to yell that out when you're about to die in a glorious manner, but that's not exactly going to kill you. I mean, unless the boss runs you over. Again, judging by the looks of that leg, I'm surprised you're still walking. Speaking of walking, that's our next W, referring to deep vein thrombosis, symbolized by the clot seen on this guy's vascular pattern on his leg. Walking also specifically refers to the need for patients to get out of bed and walk to prevent these. Surgery and trauma are independent risk factors for the development of DVTs, due to tissue trauma and a generalized inflammatory state, as well as immobilization causing venous stasis, depending on the type of surgery. DVT alone can cause fever, and signs and symptoms include leg swelling, pain, warmth, and erythema. Certain surgeries are higher risk for DVTs, including oncologic, orthopedic, pelvic, and neurosurgery. Pulmonary embolisms, which follow logically and pathologically from DVTs, may also have a fever, but PE is not really considered a common cause of fever in the post-op period, nor is fever one of the most common signs of a PE. We're not going to discuss recognition, workup, or management of either DVT or PE here, as we cover these both in depth in our internal medicine course, so check those out if you haven't. Prophylaxis of DVT following surgery is also covered in its own sketch in the surgery course. So there's where the grenades are coming from. Not sure how it's gonna help the job to throw them in front of your own cars, but sure, we'll go with it. These grenades remind us of our next category, wonder drugs. This category encompasses any drug that can cause a fever, and in fact, drugs are the most common non-infectious cause of postoperative fever. The drugs most commonly associated with postoperative fever are antibiotics, which, believe me, I see the irony here, and heparin. While it would be nice to have a simple list to memorize, drug fevers are possible with virtually any drug, as any drug can cause hypersensitivity and thus a fever. And since these fevers depend on when the drug is taken and not the surgery, they can present at any time during surgical recovery, which is why all these wonder drug grenades span the whole length of our sketch, remembering that each truck represents the timing of postoperative fevers. Okay, for our clinical case, technically he could be having a drug fever, but there's no real evidence pointing to a drug fever in his case, other than the fact that he's taking medication, so it doesn't really help us there. That's right, blood bag. We're gonna strap you to the car while we go out on our raid. Of course, here we're talking about an actual blood bag and not a human, like they used to use Crazy Carl for. I'm starting to see why he'd want to run away from these guys. Speaking of drug reactions, it's important to mention blood product transfusion reactions. If you think of giving blood like giving a medication, it fits nicely into this category. There are multiple types, all of which result in fevers. Think of this tire like a red blood cell. See how it's not burst, or dare I say it, not hemolyzed? The most common blood transfusion reaction is a febrile non-hemolytic transfusion reaction, which can happen with any transfused product, and result from an inflammatory response to transfused cytokines from accidental leukocytes sitting in the product. Signs and symptoms include transient fever, chills, rigors, and dyspnea within 1 to 6 hours of starting a transfusion. This kind is benign, and treatment is to stop the transfusion and administer antipyretics. Hey, another blood bag! Gotta get those tires all filled up because it makes sense to fill tires with blood. On the other hand, this bursting red tire, like a hemolyzing red blood cell, should remind you that there are more serious forms of transfusion reactions, including hemolytic transfusion reactions, which can be acute within 24 hours of transfusion or delayed, meaning greater than 1 day since transfusion. and allergic and anaphylactic reactions, which occur immediately after or during transfusion, like these nuclear fallout hives. I mean, if you have to be allergic to something, might as well be something as rare as nuclear radiation. Unless you're living in a post-apocalyptic world, then it's not such a great allergy to have. Before we move on from our wonder drug fevers, there are two more to talk about.
Witness me!
Well, yeah, okay, this time it makes sense. You're probably going to get smushed when that car lands. That is, unless you let go before then, because your arms are looking a bit struggly to me. Malignant hyperthermia is a rare genetic disorder of skeletal muscle receptors where certain anesthetics trigger the accumulation of calcium within the muscle cells, leading to sustained muscle contraction and muscle breakdown, anaerobic metabolism and acidosis, leading to hypermetabolism as our fever. Timing for this falls into our immediate category, since it occurs around the time of surgery. However, with regards to when it occurs with the anesthesia, it may occur at induction of anesthesia, during the maintenance phase, or even within minutes after cessation of the anesthetic. Signs include hypercarbia, seen as an increasing end-tidal CO2, symbolized by this hypercarbic black smoke, which is the most consistent presenting sign. Sustained muscle contraction, like our guy holding on for dear life, and arrhythmias are also possible. Hyperthermia is actually a later finding, and may be absent when MH is suspected. Oh, there's a trampoline for you! A nice, safe landing. Unless the car also tries to land on the trampoline, then you're kinda screwed. Treatment must occur immediately when it is suspected clinically by a high end-tidal CO2 and at least one other common symptom, and emergent treatment is to discontinue the anesthetic and give dantrolene, symbolized by our dantrolene trampoline. The patient will likely need intensive critical care following this. Here we have one of the few classics to survive into the post-apocalyptic period. Though he was previously an impressionist painter, we now refer to all art from before the war as pre-apocalyptic classical.
Who cares, art man? We're talking fevers here.
A condition similar in presentation to malignant hyperthermia is neuroleptic malignant syndrome, but this develops after use of any antipsychotic medication, most commonly with the first generations, such as haloperidol. The pathologic mechanism is unknown. Clinically, patients present with a syndrome of mental status change, rigidity, high fever, and dysautonomia, usually 1 to 3 days following antipsychotic use. Treatment is to withdraw the medication and give supportive care, and then benzodiazepines, dantrolene, bromocriptine, or amantadine can be added. Okay, so that finishes up the 5 W's: wind, water, wound, walking, and wonder drugs. But these 5 W's don't cover some important surgery-specific causes of fever. Before we depart from our Dear W's, let's remember our clinical case. Right now, the only thing that really struck a bell was that UTI. So while we finish up this next section, we ought to check on the results of his urine sample. Well, no wonder this environment has gone down the drain when you have that kind of truck emissions. Okay, so the death of the environment might be because of the nuclear war also. One such cause of fever, not already covered, is highly prevalent and can be caused by even a single dose of antibiotics. Of course, I'm referring to Clostridioides difficile infection, which can cause fevers in the acute or subacute period, hence the leaking colon pipe on the acute subacute car. There are also sources of fever that are more common depending on the type of surgery performed. We're not going to go into details, nor are these lists comprehensive, but just to give you an idea of what else to look for.
V8, V8, V8. Wait, guys, I'm up too high. Ah!
In vascular surgery, graft infections are the worst, literally. They often appear after graft replacement in groin and upper-lower extremity surgical sites, and most commonly present soon after surgery with fever and generalized symptoms of infection. After cardiothoracic surgery, fever is very common in the first 2 days, and unless there are other clinical indicators of something else going on, don't need to be worked up. Pneumonia is also more common than following other types of surgery. Mediastinitis is a serious subacute or delayed cause of fever, usually presenting within 14 days, but can be greater than 1 month. Endocarditis should be suspected in patients with fever and positive blood cultures after undergoing valve replacement. Post-pericardiotomy syndrome is another cause of fever after cardiac surgery, presenting days to weeks following cardiac surgery with fever, fatigue, and chest pain. Cool helmet, bro. Following neurosurgery, a serious cause of fever is meningitis and requires workup with CSF studies for diagnosis, as the classic clinical signs of headache, photophobia, and nuchal rigidity may be clouded by meningeal irritation from the surgery. Surgical effects on the hypothalamus may lead to dysregulation of temperature. Cool fanny pack, bro. Following abdominal surgery, intra-abdominal abscesses may develop, leading to fever and signs of generalized infection. An important source of fever and a feared complication, especially after bowel resections, are leaks at anastomoses, meaning the point of reconnection. Any anastomosis of any type can leak. Check out our abscess sketch for more information on workup and management of abscesses. Abdominal surgery may also cause pancreatitis. Postoperative fever following gynecological surgery can be due to deep pelvic abscesses or from pelvic thrombophlebitis. UTIs are also common following gynecologic surgery. Following complicated deliveries, postpartum endometriitis may develop, leading to fever, pelvic pain, and purulent vaginal discharge. Vaginal packing may allow for growth of Staphylococcus aureus or group A streptococcus, which may cause toxic shock syndrome. Postoperative fever following ENT surgery can be due to sinusitis, otitis media, parotitis, or similar to vaginal packing, nasal packing may result in toxic shock syndrome, rarely. Sinusitis and otitis media may also occur in patients with NG tubes. Okay, for our clinical case, nothing we've covered in the last section really fits, so I'm going to confidently say that UTI is probably the best guess for his source of fever. Woohoo! We did it, guys! But before we leave, let's go over what to do if your patient has a fever without an obvious source, and how to properly work it up.
Yeah! V8! Witness me!
Yep, works here too. First off, not every patient will need laboratory studies. Based on what we've talked about so far, you should only obtain labs if you suspect an infection based on the patient's history, the type of surgery, clinical signs and symptoms, and a thorough physical examination. Based on this, most postoperative patients with a fever will not need workup. In general, if you do suspect an infection, you should obtain a CBC, blood cultures from 2 sources, urinalysis, and a chest x-ray. If a wound infection is suspected, wound cultures should be obtained. If a patient has a productive cough, sputum cultures can be taken. Depending on the suspected source, more specific labs and imaging may also be warranted. Results will guide specific treatments. Treatment of the fever obviously requires treatment of the source, including the discontinuation of any unnecessary treatments like urinary or IV catheters.
By my deeds, I honor him. V8, I will ride into Valhalla, shiny and chrome.
I don't think spraying chrome into your mouth is like a smart decision, though. Definitely can't taste good. Probably gonna give you some wicked chrome lung, too. But apart from that, fever itself is uncomfortable for the patient. Acetaminophen can be used to break the fever for a few days and should not cover up any significant underlying condition causing the fevers. Let's review. Postoperative fever is defined as a fever presenting in the postoperative period of at least 38 degrees Celsius or 100.4 degrees Fahrenheit. Tissue trauma results in released cytokines, which may cause a temporary and self-limited fever. This is a diagnosis of exclusion, however. Certain patients will not mount an adequate enough immune response for a fever due to immunocompromisation or due to taking NSAIDs or glucocorticoids. Post-op fevers may be organized based on their timing after surgery: immediate, acute, subacute, or delayed. Post-op fevers may also be organized based on whether they are infectious or non-infectious. The most common infectious causes of fever in the post-op period are surgical site infection, pneumonia, UTI, and IV catheter infection. The most common non-infectious cause of fever in the post-op period is a drug-related fever. The wind, water, wound, walking, and wonder drugs mnemonic may be used to remember the most common causes and the general order that they would appear. Most fall within the acute to subacute timing. WIND stands for pulmonary causes, including aspiration pneumonitis and pneumonia. Atelectasis may be commonly discussed, but it has only been found to be correlated with fever and is not causal of fever. Water reminds us of UTIs, which may or may not be catheter-related. Wound refers to the surgical site, as well as any other break in the skin, including IV catheter sites and tube insertion or exit sites. An important wound infection to mention is necrotizing soft tissue infection, or NSTI, which is a severe and life-threatening infection, presents very early immediately after surgery, and is a surgical emergency. Walking refers to DVTs and their subsequent risk of PE. The last W stands for wonder drugs, meaning drug-related fever. Heparin and antibiotics are the most common causes, but due to hypersensitivity reactions, any drug can cause fever. Wonder drugs also includes blood transfusion reactions, malignant hyperthermia, and neuroleptic malignant syndrome. While the W's cover the most common causes of fever across the board, the specific type of surgery will also carry common causes of fever more specific to that type or location of surgery. Finally, the workup for a fever of unknown origin begins with a thorough clinical exam for signs of infection. Only if present, a series of labs and imaging should be performed to identify the source, including a UA, chest X-ray, CBC, blood cultures, a wound culture, and maybe even a sputum culture. All right, my lungs have taken just about as much of this toxic wasteland dust as they can, and I'm pretty sure we're all going to get pneumoconiosis.
Oh, it's too late for me. Get out of here. Save yourselves. Witness me.